some parallelism. This is a case, this is an old case. I did not restore this case. This was also done in our clinic, but by another prosthodontist. And you can see here on the left side, the pre-op Panorex, and the center one, an already 15-year-old follow-up lower on 4. And about 7.5 years later, the patient decided to do the same on the upper jaw, and you can see 7.5 follow-up of the implants on the upper jaw. So this is the same patient. You can see the soft tissues, how they look. Okay, some gum inflammation, especially on the lower. The patient is not very compromised with his oral hygiene, but no bone loss nevertheless. And the surgical part is followed by a prosthetic one that consists of a screw-retained provisional acrylic bridge with only 10 teeth. In these healing periods, we try to avoid cantilevers, and this provisional acrylic bridge is screw retained to the multi-unit abutments. Whenever possible, if we have if the availability of bone is not an issue, the surgeon can insert 6 implants instead of only 4, and we can have the all-on.
Pedro, please switch on the microphone again. We are 2 minutes without sound.
Sorry, my friends, I don't know why this happens, because my microphone seems that he's disconnecting by itself. So please, Lev, whenever this happens again, please call me again. I will have my phone next to my laptop, and I hope we don't have problems in the future. So may I continue? Lev, can you hear me now?
Of course, please, one slide before.
One slide before. So I was saying that this slide corresponds to the same patient I was showing pictures before. This patient, he's a heavy bruxer. You can notice that the occlusal surfaces are really abraded. There are some signs of repair of the central incisor that broke. The acrylic, the pink acrylic, just broke. And you can also see how we build the emergence profile with this type of restorations. Can you hear me now?
Yes, good.
Okay. So why do we choose screw-retained bridges with this kind of restorations? Well, because the maintenance protocol implies removing these bridges every 6 months for cleansing and by the hygienist or the dentist, and this makes it easy to repair the prosthetic work if we have any kind of complication, because we just have to unscrew this, and this can be a big problem if you opt for cemented restorations. So the standard protocol is quite simple. We start by the day before the surgery, take some pictures of the patient, take some alginate impressions, and on the surgery day, if there are still teeth present on the mouth, we normally extract them. In most of the cases, the oral surgeon has to do some bone reduction for aesthetic purposes. I will not go very deep into this subject today. The implants are placed and also the multi-unit abutments. And then comes the prosthetic part with silicone impressions, the bite registration. Normally teeth are tried in before we deliver the provisional acrylic bridge. Then, like in other surgeries, we take a panoramic X-ray and with also some photos. So, regarding the follow-up of these cases, patient come 10 days post-op for removal of the sutures, oral hygiene, and some occlusal check. And we repeat this at 2 months, 4 and 6 months. At normally about 4 months, we start to refine the emergence profile because, as you well know, after or during the healing period, the soft tissues will rebound and we will somehow lose that shape that we created with the acrylic, and we will refine this during this period, starting at 4 months. At the end of 6 months, normally we start the final restoration.
The action of returning something to...
And we do some silicone impressions to record the new position of the soft tissues. We mount the casts on the articulator. We do teeth drying. If we opt for hybrid bridge with a milled titanium bar, I normally opt to also try this to look for some potential problems, or we can also try in a copy of the, a milled PMMA copy of the trying if you go for example, for a full zirconia bridge. And then you can deliver the bridge. After the delivery of the restoration, we normally ask the patient to return every 6 months for oral hygiene and also to check if everything is okay. And our patients are advised to buy an oral irrigator, and they're also given a splint. So this is the first case. I will show you the classic protocol with these minor changes I introduced over the year. This patient is a quite young patient. She was at that time under 40 years old, and she came to us really unhappy with her smile. She was unaware of having severe chronic periodontal disease because this was not diagnosed prior to her coming to our office, but she was feeling that something was not okay with her teeth and her gums because she already had lost some teeth, and the situation was getting worse and worse. So these are our protocol, the photo protocol. You can see that the patient is asked to smile, but she's really not very into smiling. She looks really unhappy. This is the intraoral protocol we are doing for pictures also. Most of the teeth, if not all, had grade 2 or 3 mobility and deep pockets from 9 to 12 millimeters periodontal pockets. So we presented the patient several options, treatment options. She decided for extractions and implants. This is the initial pre-op panoramic X-ray. You can see the marked periodontal loss, bone loss, that is generalized. And we did the protocol I already showed you before. And this is the post-op Panorex. I would like you to notice that we kept some teeth. Normally the protocol is not maintaining posterior teeth, but we realized that over time we realized that keeping second molars or sometimes even third molars, it's wise, because patients who lose all their teeth, they also lose proprioception. This is really important for namely protection of the bridge work, but this is also really important for posterior support of the joints. In this case, as you can see, we decided not to load the posterior implants on the lower jaw. We can do it, but we decided not to. And this is the 6-month intraoral photos after, before we decided to start the final restorations. Okay, you can notice in these pictures that we are only using 10 teeth. So normally we are not delivering this provisional work with molars. We change this over the years, as I will show you later. And you can see that the patient's smile is completely different now. And the patient is eager to smile. She even lost weight because this was really important for her in her life. She couldn't smile before. And this is the profile of the provisional bridge we are delivering the patient. You can see that the pink acrylic is rather convex. We should avoid having concavities or flanges in the emergence profile. I often see this in this kind of work. This you should avoid by a really good planning of the surgery. And again, the intraoral photos with the emergence profile, you can see the areas where the provisional bridge were touching the soft tissues. We have a concavity, and this is caused by the convex emergence profile we create. And in the marked areas, we don't have that. How come? This is because we did not extend our provisional bridges to these areas, and we manage this problem later. After we do these the final impressions, we simply ask our dental technician to use a big round burr over the gingiva of the model and to grind it to create the same profile we did with the provisionals. So this is the resume of what I was saying before, okay? And in some cases, in some rare cases, this doesn't happen too often. The surgeon is not doing some bone reduction, and we have to create false papillas. In this specific case, you will see that the position of the implants is not perfect, and this is due to the fact that this patient lost these 2 implants, or the previous 2 implants, during the healing period, and these the implants that were placed before, the implants that were placed afterwards were not placed in the perfect position. So in this case, we have to opt for some false pink ceramic papillas. So all these papillas are in our natural false papillas, except 2 that are pink ceramic. About bite registration, how do we do it? This is a modification of the classical approach. When I learned this more than 10 years ago, we were using these wax rings like in full denture, but they were screw retained to the abutments. Nowadays, I'm using this technique with some telescopic wax rim, and I'm using this Gothic arch technique for the bite registration. So this is another patient. This patient underwent an all-on-4 protocol on the lower arch, and we did an all-on-6 protocol on the upper. This is during the bite registration. On the wax rim, we do exactly like in full dentures. We have to check the lip support, the midline, the position of the canines, the line of smile, and with this device we are registering the what we call the reference position. I will explain later what this means. This is a simple device. If you want to know more, you can go to a Candelor site. They will explain you how this is working. It's quite simple. And then after we have the position we want, we register this with a fast setting silicone, and we take an anatomic face bow registration. So after 6 months, we start with new silicone impressions to record the position of the new position of the soft tissues. We mount the upper cast and the lower cast on the articulator. We use, as I told you before, these telescopic wax rims exactly like in full dentures to get information about lip support and the position of the teeth. So then we should do some try-ins. These are important, of course. We try in the teeth. I always love to, this is important for me, to try also the milled titanium bars. Even though they are digitally planned and milled, I had some problems before with the files and not well-fitting titanium bars. So I would advise you to try them in the patient mouth before you deliver the bridge work. So after delivering these bridges, we are also giving the patient a splint, and we control the patient. So this is, I will go this fast. This is the impression. I'm splitting the impressions. Okay. Before the impression, sorry, I'm splitting the impression copyings, as you can see here. Before I do the impressions, this is the areas to manage by the dental technician for the correct emergence profile. This is how we mount the casts on the articulator. I'm using the provisional bridges for mounting the casts on the articulator, and also an so-called RP wax that I will explain you also later how this works. Okay. So these are the checkup bars. These are meant to check if your impression and if your master models are precise or not. And sorry, this is the setup that the teeth setup that the dental technician sent us, and we will try this in the patient's mouth. We can see how the patient feels, have an idea about the occlusion, the aesthetics, and also about phonetics. So the patient approved this, and you can continue with the work. Then you order the bars to your dental technician. This is how they come. You can see them. These are not fused. These are milled titanium bars. Along the years, we have tried several designs of bars. These are just one design we used. You can see some extensions of the titanium for each tooth. And we are here checking the fit to the abutments and the bridge work delivered. Okay. This is the final Panorex, and this is the post-op extraoral photos. So I hope you're not bored with this presentation. This is the classic protocol, and I will now show you how we are doing now in this type of full mouth restorations. During my presentation, I will also show you some pictures of the Azores. This is on the horizon. You can see Corvo Island. This is the smallest island in the Azores, has less than 400 people living there. And this picture was taken from Flores Island, that in fact is the most western territory of Europe. Okay, so why exactly are we using a new functional protocol to restore this type of cases? Because, as in this picture, sometimes everything looks fine, but the boat is sinking. What I mean is, sorry. Along the years, we had some cases that were looking really fine, but were not working. Sometimes we had problems starting on the provisional phase. Most of the times we are having fractures or deboning of the acrylic teeth. But also other times we were having no problems during the provisional phase, and as soon as we started the final restoration, the problems were also starting. And I imagine that you, as me, I don't want these kind of problems in my office, not only because they consume time, but this is frustrating for me and for the patient, and this is also costing lots of money. So what happened is that in 2013, I decided to deepen my knowledge on occlusion, and I went to Vienna to study occlusion with my mentor, and I guess some of you also mentor, Professor Rudolf Slavicek. You can see him in the center of the image, along with some other colleagues, most of them from Russia and from Ukraine, but also from Romania, from Spain, and from Italy. So this was taken in, I think, in 2015 or 16, when I finished my therapy course in Vienna. Really nice to go there. And now I would like to explain to you why, for you that are not familiar with this gnatological approach, why it is important to have this to switch the brain to these new ideas. So, thanks to a gnatological approach, we can perform a complete diagnosis that allows a treatment plan, taking into account the signs and symptoms of dysfunction, and thus reducing the therapeutic risk not only for the patient, but also for our restorations, as I was telling you before. With this philosophy that I learned in Vienna, we have a really precise control of all of these things that I will explain, like the vertical dimension, the inclination of the occlusal plane, a precise position of the mandible that we can control, also the curves of Spee and Wilson. And so all of these characteristics of the occlusion are really precise controlled with this philosophy. So now, for you that are not familiar with this Vienna approach, this is the classic scheme from Slavicek that is explaining the cybernetic system of the masticatory organ. So what I would like you to focus is about the functions of the masticatory organ. There are 6, but we as dentists normally are not focused or even are unaware of all of them. So we as dentists normally focus on aesthetics. Of course, every dentist wants to deliver some really nice looking bridge work or crowns or wherever, or composites. Sometimes we are also focusing on mastication, but we tend to forget all the other functions. And there is only, there is one that is really important for us. This is stress management. We now know there is growing evidence every day that bruxing is really not a parafunction, as I learned in university, but rather another function of the masticatory organ, and it's really important for us to cope with stress. So about 4 years ago, I started to implement this protocol that I will show you now to restore this kind of implants. So we start by a silicone impression again, just the same as before, and then we are using this protocol that I will explain thoroughly in a few minutes. So again, some pictures of the Azores. I discovered scuba diving here in the Azores because there is not much to do besides enjoying nature. And this picture was taken during a really nice dive in Santa Maria Island. And this is, if you're into the ocean, this is a really nice place to come. This was probably one of the most amazing sensations I have in my life. Can you hear me?
Yes, okay.
Okay. Sorry. So this lady, a very nice lady, she emigrated to the United States early when she was young. Then she graduated as a nurse, and as soon as she retired, she came to us complaining of lack of retention of both her full dentures, and she was looking for a fixed solution. So you can see here, these photos are important for us. We start by analyzing the patient when he enters our office. You can see that she has a class 3 profile. Okay, this is quite obvious. This is the intraoral pictures of her dentures that were really loose. The same protocol for intraoral pictures. And on the initial panorex, you can already suspect that, sorry about the picture is not that good, but we can suspect that the surfaces of the condyles have some problem. We can see that there are some flattening. I think on the right side, sorry, on the left joint, it's easier to understand. And in this case, normally we prefer to do this case, the upper and lower jaw at the same time, the surgery and the prosthetic work, but this patient asked us to do this in different days. So we started by the upper bridge, and a few days later we did the lower surgery. You can see here that I'm checking the fit of the impression copying to the multi-unit abutment. Using multi-unit abutments are a must because they make this really easy. This is the first impression. During the first impression that we do, I never use light body silicone to avoid the silicone to get into the flap. So most of the times we have some voids on the putty silicone that can easily be managed with some pattern resin, as you can see. Then this is the bite registration. It's not the one that I showed you before. This is probably one of the first cases we did for after I returned from Vienna. So this is a screw retained wax rim. And in this picture, I want you to notice that there are some thinning of the acrylic on the edge of the 11, tooth number 11. And also I have to use pink acrylic on the papilla area on the lower teeth to close the prosthetic chimney. This is caused by the skeletal class type of the patient. And later on, and before I did the final impressions, I decided to change these straight multi-unit abutments by angled ones to move the prosthetic chimneys of these teeth in a more palatal position. So you can see here in these areas that I marked with some arrows, these are the teeth that I changed the multi-unit abutments before the final impressions, okay? And I want you also to notice that this is a mistake. This patient has really little posterior support. Nowadays, whenever we cannot put or add some teeth on the posterior area to avoid cantilevers, we are changing the second premolar and using a first molar that has a wider occlusal surface to aid with occlusal support. So this case is not perfect. It has some mistakes, but I hope you can learn with the mistakes I did along with this case. Okay. So after 6 months, we can start the new bridges, and the same again, silicone impression. You can see here, I normally split these pattern sticks that are used for splinting the impression, and normally, the purpose of this is to minimize the contraction of the pattern resin and to have a better fit of the titanium bar. So I cut these. I make these cuts on the splint. And then I add some really small portions of pattern resin, and I wait 20 minutes until they are fully set before I take the impression. So this image is meant for you to understand the importance of the checkup bar. You can see here that the fit is not perfect. If the fit is not perfect, this will mean that your final restoration will not be passive, and this will increase the risk for not only the implants, but also for the restoration, like chipping or fractures of the acrylic or ceramic. So this needs to be fixed. And this is the lower impression, the same protocol, okay? And now comes the new protocol that we are using from Vienna, okay? So before I explain you the protocol, I would like you to give you this quote from Slavicek, is that the key point of any treatment must be a valid diagnosis. It is the only point to initiate a causal therapy. And with this, I want to transmit the idea that in Vienna, I learned that it's really important to start with a good foundation diagnosis. So really, good diagnosis is paramount for the success of our treatment on the long term. So this is what we are doing. We are looking for as many information we can use that are valuable for our final diagnosis. So now we start with this protocol. We start asking the patient about his systemic problems, and then we go to the dental history analysis. In this case, the patient was mainly complaining of a limited open and some pain on the area of our joints. TMJs, of course. Then we do some muscle palpation. A plus means that this is tenderness to palpation. 2+ means really pain. You can see that on the right side, the patient is feeling worse than on the left side. We have pain on palpation on the temporalis muscle, the anterior part of the muscle, the pterygoideus medialis. This is palpated inside the mouth, and also on the joint area, on the lateral pulse on rotation, and also on the radial joint space. Well, sorry, normally when we have tenderness or pain on the retral joint space, this means that we are somehow loading or overloading this area. This is, we call it the bilaminar zone, and this zone is not prepared for being overloaded, okay? So with this information from the muscle and joint palpation, we can already suspect that we are having overloading problems on the joints, and we are already thinking and correlating this with the findings we had on the panorex we saw before. So now we are searching also for problems with the cranial nerves. Sorry guys, I'm losing a battery. We are asking the patient for complaints regarding chronic pain and myofunction disturbances, not in the case of this patient. She was not addressing any kind of chronic pain. And then we are proceeding with the RP wax that I showed you before. So this is a basic protocol we learned in Vienna. This is a bite registration made on a very hard pink wax. We call it beauty pink wax and L wax. And the aim of this registration is to get what we call the reference position. So the controlled and enforced lateral border of the mandibular movement, in which the tissues are not of the joint are not loaded. So in fact, this is the zero position of the joint. This is an unstrained and reproducible position, and it's related with the joint, not with the occlusion. Okay, and this reference position will be the starting point for not only our condylography, but in some cases for the start of and the end of our treatment. So this image, this is adapted from a presentation from Dr. Miguel Assis and Alejandra Londono, and this is explain you in fact what is the reference position. So this is the most posterior and strained position of the TMJ. And we are also using some other devices to collect information about not only the static, but the dynamics of the occlusion of the patient. And we are using what we call the occlusogram. This is a green or blue wax that's normally used for removal prosthetics in the dental labs. I'm analyzing several positions. ICP means maximum intercuspation. Mediotrusion right is the movement of the chin to the left side, so this is left lateral intrusion. And what I would like you to notice is that my provisionals had several problems, okay? In these occlusograms, the areas that are perforated are the areas in contact where the upper teeth contact the lower ones. You can see that we have some minor contacts on the anterior teeth. This is quite okay because we want the anterior teeth not to be much loaded, because this area normally is when we're talking about teeth, these are sensitive organs, so they are not prepared for being overloaded like posterior teeth. But for example, you can notice that the area corresponding to the right second premolars had almost no contact. So this is a show of posterior support on the right side. Okay, we have some other problems like in the metrusion right. I would like to see the left canines guiding the movements, but we have no contact there. Rather, we can see the contacts or the guidance made by the premolars, for example. Okay, and on the bottom we can see, for example, that the protrusion is made by the right canine, but also I can detect what seems to be like interference on the left second premolar. Okay. So we are also using this great device. This is called the breast checker. Breast checkers are really thin, 0.1 thickness vacuum pressed polyvinyl sheet that are colored by a food colorant, and they are used to check for 2 days or for 2 nights in a row the pattern of the occlusal contacts of the patient. So what do? We give 2 breast checkers to the patient. When we tell the patient to use 2 days in a row, he should only take this out for mastication, so for at the meal times. But he should use it even if he's working, because we want the patient to be wearing this in normal situations, for example, under stress. And the second breast checker, the patient is advised to use it 2 nights in a row. Okay, then we can analyze the occlusal patterns that we get. In this case, we can see that we have no posterior support on the right side, and we have mainly bruxism on the premolars area and also left canine. So then we are doing this axiography. Okay, so our patient are undergoing this examination. This is also called axiography. You can see that this is the patient has an upper face bow that has attached 2 flags. The flags are those electronic devices with a square shape over the ears, and we have a lower face bow that is attached to the lower teeth. This is glued to the lower teeth. And then we ask the patient to do several movements like open, close, protrusion, retrusion, mastication, speaking, etc. And we can record on these flags the movement of the hinge axis, and this will be recorded in our laptop, as I will show you later. So, and now for you guys that are not familiar with this concept, you will ask me, for example, why are you doing condylography? What is the purpose of condylography? Well, according to several studies, TMJ abnormalities cannot be reliable assessed by a clinical simple examination. So we need more complex diagnostic tools to get a precise diagnosis on our TMJs. This condylography has a sensitivity and specificity, 50% of specificity, and this is a high precision measurement. It has a really high diagnostic value, but it has also therapeutic relevance. This means that we are using this this device not only for diagnosis but also for our therapy. So this is different from CBCTs or MRIs, that we cannot directly use them for therapeutic. Okay, it is highly reproducible and allows us the analysis of dynamics that we cannot also do it with CBCTs nor with MRIs. So with this technique, we are also looking for the hinge axis of each joint. There are many systems doing axiography, but not all the systems use hinge axis location. So why is it so important to find the true hinge axis of the patient? Because this, as you probably know, the dynamic mandibular movements consist of both translation. Translation occurs between the disc and the eminence of the joint, and we also have rotation on the lower part of the joint between the disc and the condyle. If we are doing condylography, but of the hinge axis. So if we don't set our hinge axis, we will get some curves that are not that are distorted, as I will show you. So you have this scheme here. The pink sphere is represents the condyle, and the curve is the eminence. And you can see here that the condyle is doing a translation movement, so downwards and frontwards, and we have these these blue spots marked, and this is the hinge axis that corresponds to the center of the rotation of the joint. So this is with the correct position of the hinge axis, and you will see the same movement we ask the patient to do, but off the hinge axis. So this will result. This is exaggerated, but this will result in a distortion of the curve. With this kind of distortion, we cannot really have information about the health or not, of our joints, and this has little therapeutic value. So we should always look for the hinge axis when we are doing axiographies. What about the reference plane we use with this concept? So I guess most of you are getting bored. Sorry about that. I will try to continue. The reference plane we are using with this Slavicek concept is what we call the axial-orbital plane, and it is established from the hinge axis point to the suborbital cutaneous point. Okay, this is a lateral ceph we get after we do this condylography. After we find the hinge axis, we are marking the hinge axis and you can see the suborbital point also marked on the skin. And then we trace a line and we get the axial-orbital plane. So this is the reference plane we are using with the concept. There is another plane that it's also important, and I can show you here. Sorry, again. And this is the occlusal plane. In these cases, when whenever you use acrylic teeth, you have to do a trick so you can locate your teeth on the X-ray. So what we are doing is we are doing.
Pedro, please switch on the presentation again.
Sorry?
Switch on the presentation again. I can't see it.
You cannot see? No, I'm on. You cannot see? Lev, can you see me?
Yes, I see you. Okay. Thank you.
I think that we might have a problem with the connection because my presentation is on. Can you are seeing me now, right?
Perfect. Okay.
Okay. Sorry. So as I was saying, we are using some lead foils from intraoral X-rays that we glue to some teeth, like the central incisors and the first molars. In this case, we don't have first molars, so we are using the second premolars. So we can trace our occlusal plane that is defined by the tip of the central incisor and the distal cusp of the first molar. Okay? And why do we use this reference plane, this axial orbital plane? Why is it important? I traced this plane. It is represented by this yellow line that you can see crossing all these images, and this axial orbital plane is the same on the picture I took. The lateral picture of the patient is also the same we are seeing on the lateral ceph and on the tracings. This axial-orbital plane is represented on the articulator by the upper arm of the articulator, and is also represented on the curves by the x-axis. Okay, so we have some, I would call it some unified system, and with this plane, I know that what I see on the articulator is exactly the same that's happening on my patient, and also it's the same that I can see on the X-rays and on the curves I trace on the lateral ceph. Okay. So I will not go explain very deep about what we get from the curves. This is not the purpose of this presentation, that it's already long. I will just explain you a bit, not too deep. So this is the open-close curve we get with the condylography. So I'm asking the patient to open and close her mouth, starting from the reference position. So 0 corresponds to a reference position, and I get these kinds of curves on my laptop. So we are analyzing, we have this protocol, we are analyzing the curves for quantity, for quality, for symmetry, for different characteristics, and we can see that open-close is considered a symmetrical movement. This means that ideally, when I ask the patient to open his mouth, the mandible should not shift to one side or the other. And the movement should be, it should have at least about 38 millimeters of length from the tip of the incisor to the other tip. So we can see that after experience, I can know that the movement is reduced, especially on the right side, also on the left side. I can know that the shape of the curve is telling me that the idea I had from the X-rays was right. This patient has already some erosion of the articulate surfaces of the condyles. This means osteoarthrosis. Okay. As you can see there, we have flattening of the surfaces, and this is the same idea we have from analyzing these curves. Okay, and it is important that you understand that the software or the curves itself, they don't give us a straight answer. This is not the kind of protocol for if you are looking for easy answers. You have to combine all the information from these X-rays, from analyzing the muscle palpation, from analyzing the models, the breast checker. So all the information I've been showing you, it's important for the dentist to get a final diagnosis. Okay. And then we mount the casts on the articulator. So this is the kinematic face bow, the special face bow we are using. Okay, this is a side view of the same models. Okay, I would like you to notice that on the left side, I'm using the provisional bridge to mount the model, the working model on the articulator. Okay, this is the lower. Okay. And we like to analyze the models in maximum intercuspation, but also in reference position, as we can have here. Okay. And another important characteristic of this protocol is that after doing condylography, we get this information to set our articulator. So we are using this fully adjustable articulator. This is the information for the right joint and for the left joint. You can see the sagittal condyle inclination on the right is 36. It's different on 5 degrees from the left side. Also, these inserts are different, And these are giving information about the shape of the implants that is flatter on the right side than on the left side, okay? On the bottom part, as you can see here, we have the image of these three like Lego components, and this is what we call the incisal table. And this incisal table allows us to create the occlusion for the patient according to Slavicek's principle. So we have different colors that correspond to different inclinations of the cusps, okay? And we also get these tables with some really valuable information like the skeletal profile of the patient, the position of the teeth, the vertical dimension, and we can analyze what are the problems, what is okay, and what we need to change, okay? Again, this is this information that I showed you is we get it after doing these tracings, okay? Like orthodontists are used to do this. Normally, prosthodontists don't do this. We do this in Vienna. And then we have the bite position we are choosing for our patient. In this specific case, I would like you to think that is with these kinds of joints that I showed you, really destroyed articular surfaces of the condyles, would you feel safe to restore this patient that is complaining of pain and limited opening and using this bite position for your final restoration? Probably not. So what are we doing here in Vienna? So in case of internal derangements of these joints, the RP, so the reference position, is considered pathological, okay? And we call it DRP. This means deranged reference position. This DRP is less reproducible, but is still used as the starting point for our condylarthrography and for our initial therapy. Then we should find a new position that will improve the condition of the patient, okay? It is important to notice that if the patient is having severe pain or inflammation on the joints, there is no reference position possible. So normally in these cases, we have to provide the patient with an emergency splint so we can reduce the symptoms, and then we start the condylarthrography. So this scheme summarize what I was trying to explain to you, that if we have a reference position that is okay, this means physiological, we can use it for our therapy. If it's not, we call it deranged. We should find a new position, a bite position, and then start our therapy. In this specific case, we decided not to use the reference position, and we tested several positions, several bite positions, in order to get our therapeutic position. According to the Wilks classification of the internal derangements of the joint, this is what we call an osteoarthrotic left and right joint. And in Vienna, we are using this technique that is called control mandibular repositioning to get a new position of the bite of the patient. So with this new bite, we want to unload the joints and create a new position that is healthier for the patient. Now, the question is, and can we improve the health situation of both joints of this patient that has, as you told us, arthrotic joints? Yes, we can. Okay, according to Sado, in this paper that was, this is from 2009. This is a patient that underwent orthodontic treatment, this is a rheumatoid arthritis patient, and he had both his TMJ destroyed. You can see on the left side, upper and lower. So upper is his right joint, and lower is his left joint. You can see that both TMJs are really and severe abraded. On the second image, you can see that there are morphologic changes on the shape of the joint, and this is you can see that the density of the bone is increasing a long time. And on the right side, the right images, you can see the 4 year and 2 months post-op. So what does this mean? This means that we can, in fact, improve joint condition of these patients. So if we unload the joints, we can go from the left images, to the right ones with a change on the morphology of the joints. But this is also important to notice that if we are not using the correct protocol, and if we are overloading these joints, we can go from the right images to the left images where we get destruction of the joints. So to be sure that this therapeutic position is really the best for the patient, we can do some tests. We do some test bites, and we can even give a splint with this new position for the patient to wear. So this is what we are doing. We are using some fast setting silicone that are created. These test bites are created in this special articulator. This is called the variator. On the left image, you can see the fully adjustable articulator that I showed you before. And on the right side, still on the left image, you can see this special articulator. So we call it the variator. The variator is also an articulator from Gamma, the brand that is selling this. And this articulator has these special housings. I have it here. I don't know if you see it, okay? But we have these special housings corresponding to each condyle. And these housings have these screws, and this allows us to move the joint on the upwards or downwards, and also frontwards or backwards, okay, independently for each condyle. And then we have this screw here that allows us to move left and right, or what we call the y-axis. And we can do this with a precision of 0.1 millimeter. So this is what we are doing. On that image, you can see the new position that we created for the patient, so the TRP, and this is the one we are using for the final restoration. Okay, so this is the new position. We have the master models with implants already mounted in this new position, and we can ask the dental technician to start his work. Okay, these are some silicone keys done with the provisional screws on the master models, and this will help the dental technician to guide him during mounting his teeth. Now it follows the teeth drying, and I will try to explain you the occlusal concept that Slavicek is teaching us. And this is, in fact, a kind of canine guidance, but the canine gets some help from other teeth, from the premolars to the mesial ridge of the first molar. So, in fact, Slavicek is saying to us that he did not create this concept. This concept, this occlusion concept, comes from observing nature. We are just replicating the concept. Okay, how does this work? we are dividing teeth in different areas, and 3 ones are for control. The ones marked in orange are for guidance, and we have the areas marked in red for support also of the joints. Okay, this is from another case. This is one of our first cases we did from Vienna. This is a full wax up according to the concept, and for another patient with an upper and lower, sorry, it's not lower all on 6, but rather all on 4 too. Okay, this patient opted for an upper zirconia, full zirconia bridge, and a lower hybrid titanium acrylic one. So we managed to have a better control of the occlusion, doing a full wax up of all the upper teeth. You can see on the right image that we have a steeper canine, and from canine to the first molar, we have the cusps are getting less inclined, and this creates this sequential disocclusion that I was telling you about. Okay, this is the full zirconia we got from the wax up. And for this specific patient, the patient I'm showing you the case, the patient decided to get some hybrid bridges, titanium acrylic, so we could not do or perform wax up. So we are using a simpler approach with a Kynan guidance. Okay, this is the basics of the occlusal contacts. We want the palatal stem cusps of the upper premolars and molar to occlude with the distal fossas of the lower premolars and central fossa of the molar. And this is one of the most important pictures I would like you to take home, this image. This is what we call the retrusive control. This is quite important because having the palatal cusp of the upper first premolar occluding in the distal fossa of the lower first premolar is the key to get this therapeutic position. This means that if we fail to do this, the patient, when closing, will not close in our new position. So we are normally going downwards and frontwards, and we can also go like left or right, but we are always going decompressing the joints, so going downwards and frontwards. And if we fail to do this kind of occlusion, the patient will close not in our new position, but in his previous maximum intercuspation. That is not okay. So this is quite important. So we are creating some Kynan guidance, this occlusion, okay? This inclination is also, we can precisely control this, having the same inclination as the contralateral eminence, okay, the SCI. You can see here what we are doing, quite simple. We are also having the central incisors not really having much load, but slight contacts on protrusion. And this is the teeth setup that the dental technician prepared for us. And what is really important, and I would like you to note, is that this vestibular or buccal site looks quite nice. Okay, we as prosthodontists are normally used to analyze models from the buccal side. Everything looks really nice, but when we look from inside, from lingual, you can check that the occlusion that I ordered the dental technician, it's not what we want. So we had to change this, okay? Get used to look your restorations from the inside on the articulator. So after managing these problems, we did teeth drying and we delivered the bridge to the patient. Okay, you can see here the emergence profile, also convex. Okay, the same on the lower. I had to grind a bit on the pink acrylic because we had a concavity there. The technician was not doing this properly, and we delivered both the bridges, titanium acrylic. You can see here the static occlusion of the patient and some dynamics, the protrusion, with the protrusion right and left. You can see that there is this occlusion on the posterior areas. Okay, no interferences also. And most importantly, the patient is returning every year on vacation from the United States, and last year she returned and reporting no pain on the joints, no pain upon opening the mouth very wide, and she's also reporting overall improvement of her condition. I was trying to get control condylography for this patient for the last 2 years, but I was unable to do it. I will try to do it this summer if COVID allows us. I would like to show you this, but unfortunately I don't have this control condylography, and I would hope that the curves would show some improvements. Okay, so I'm really finishing my presentation, that it's already quite long. Yes. I'm leaving you with this image. This is taken from Fayal Island, also here in the central group. I'm also going to Fayal to work there. And the big mountain you see, it's another island. It's called Pico Island. It's the highest mountain in our country. And Fayal Island is known for its really popular place amongst sailors, because normally sailors coming from the Caribbean, the first stop they get on the Atlantic Ocean before they get to Europe mainland is the Azores. So they normally stop at Fayal. So it's also really a couple of islands really nice to visit. So take-home message for you guys. All-on-4s and all-on-6 protocols work very well in fully dentulous patients, or in those patients with most or all of their remaining teeth very compromised. The limited number of implants make it easier to clean, and the use of multi-unit abutments compensate for the angulation of the tilted posterior implants, and avoid damaging implant tissues whenever the bridge is removed every 6 months for hygiene. Okay, whenever possible, it's also important to try to keep some molars for proprioception and for posterior support of the joints. And the condylography is important and enhances also the final result, because we may insert the patient settings on the fully adjustable articulator. So we are doing really customized work, and because it's allowing the mounting of the cast according to the real axial orbital plane, preventing mistakes caused by arbitrary mounting of the casts. And finally, because it helps the dentist to diagnose and eventually, as I told you, to treat TMJ disorders with the full arch mouth restorations. So I would like to finish with this quote from my mentor: "Knowledge is most meaningful when shared with others." I hope you enjoyed this presentation, and thank you again. On the right corner on the bottom, this is my email. If you have any questions, you're welcome to email me. I'm now open for some questions.
Thank you, Pedro.
You're welcome.
Коллеги, если у вас есть какие-то вопросы по презентации или по концепции, пожалуйста, задавайте. Что-то было неясно, хотели бы уточнить, пишите в чат. Pedro, you have some questions in the chat.
Okay. It's in the chat?
Yes.
Let me come here again.
Вопросы можете задавать на русском, я их переведу.
Can this method be used on the patient who is receiving biphosphonate after cancer for a while? Sorry, I can only understand this this question. I will try to address this question. Well, as I told you before, I'm not an oral surgeon. We have not much experience with biphosphonates, but we have currently a patient that probably underwent biphosphonates or other type of medication that's interfering with the bone metabolism, and we are still, and already for probably 2 years, we did the surgeries, and we are still on the provisional phase. Why? Because this patient every once in a while has some symptoms and is developing more and more bone necrosis. So I would be really, really careful about going to these kinds of surgeries on patients undergoing biphosphonates, especially because doing this type of surgeries implies big flaps, implies taking the periosteum off the bone in a really large area. So I think that if you're doing this on a patient, we'll do it carefully. So I don't know if I answered the question. Sorry, I don't understand Russian, so I will try to answer the English questions. If I use MRI for diagnostic, well, I'm not using MRI for diagnostic, but MRI is really useful, and we can also use it despite we are using condylography. Of course, you can use and whenever you have some doubts, or if you want to give an extra to your diagnosis, MRIs are welcome. Yes, we don't have it in our office, and it's not really easy to get MRI here. So it is an important tool, and it has also high diagnostic value for these kinds of TMJ disorders. If we have some internal derangement of the joint, yes, of course, you should use it, and you can use it. So another question from Vasil 9147: how we can use recapture of the disc on natometer or when we do axiography? Well, this is not an easy question. This takes time to learn, but in trying to simplify this, or to oversimplify, with this variator, we can, as I told you, we can unload the joint. This means that we can if we had not a chronically luxated disc joint, but recent luxation, most of the time we can recapture the disc by increasing the space for the disc. So this is the basics. I cannot go deeply into this subject because this really takes time. For last patient with osteoarthrosis, this is from Adrian Badarau. Thank you for your presentation. For your last patient with osteoarthrosis, maybe I was not attentive. When was made the initial therapy for TMJ? After 6 months? Yes. So ideally, and I will repeat, ideally, we should start this protocol right from the beginning. This means plan the new bite, the new position for the teeth. But for logistics, we cannot do this right now. So we are starting the protocol only for the final restoration. But before we start or we deliver the reference position is physiological, is it healthy for the patient or not? So in the cases that this reference position is a deranged one, this means it's not healthy for the patient. Before we start with the final prosthesis, we are doing this so-called CMR sessions. This means controlled mandibular repositioning sessions, where we test several positions, bite positions for the patient. We do this by palpating the muscles and the joints, and we are aiming to reduce, or even better, to bring to zero the muscle palpation. This means that the muscles are guiding us for a new position, a new healthy position that we call it the therapeutic position. I don't know if is there any more questions in Russian that you can translate, Lev?
Окей. В качестве комментария про лекцию можно отметить, что лектор хотел показать, какой подход он использует, а именно концепцию венской школы профессора Славичика и применение концепции последовательной дезокклюзии с клыковым доминированием, которая моделируется после различных диагностических процессов, начиная от пальпации жевательных мышц, обследования сустава и планирования на временных реставрациях. В том числе данную концепцию можно применять в различных направлениях и не только на этапе окончательного протезирования, но и на этапе временного протезирования. Если какие-то вопросы возникли по презентации, пожалуйста, напишите в комментариях, и мы их обсудим. Okay, you have a question.
So I have a question. If this is predictable for Bruxers, is this Bruxers? Is this the question?
Yes, it is. It is a question.
Okay. Yes, we are using this for Bruxers for several years. The main problem for implants. Yes, we are using this for Bruxers. The main problem with Bruxers is not normally the implants itself, but the bridge. If we are not following this protocol, normally Bruxers tend to fracture or chip their bridges. So yes, this works with Bruxers. Any more questions? So, Lev, I don't know if you have any question for me.
I haven't questions. Also, I did not see the questions in chat. And I'd like to thank you for the presentation, to introduce another approach. Thank you very much.
So I would like to thank you all for seeing this webinar. I hope that during these really tough times that everyone all over the world is facing, my webinar was somehow useful, and I would like to welcome you here to if you want to results. Okay.
Okay. Thank you very much.
Thank you.
And also,
Thank you. Okay. Bye bye.
thank you. See you. Bye.
See you. Bye. Thank you.
Goodbye for everyone.
Goodbye.
Всем хорошего вечера. До свидания. До новых встреч.